So you break an arm, right? You go to the hospital, the x-ray shows this, jagged white line, and the doctor just points at it and says, there it is.
Right. Very straightforward.
Yeah, it's binary. It's comforting to have things neatly categorized into like broken or
Mm-hmm.
fixed.
Mm-hmm.
But looking through this brand new stack of medical data from today, which is Monday, May 18th, 2026, this rapidly expanding world of cosmetic gynecology has completely broken the X-ray machine.
It really has.
Because we are looking at a diagnostic and, well, a procedural landscape that is just incredibly murky.
Yeah, the gap between what a patient feels, what a private clinic promises, and then what the medical establishment can actually prove, it's massive.
Exactly. So consider us your shortcut today to becoming well-informed on a topic that has, it's completely exploded in popularity, but it's wrapped in all this confusion and marketing hype.
There's a lot of hype.
So much. We've got a really fascinating stack of sources for you on this deep dive. We have a brand new 2026 clinical pilot study from JSIMED Central. We've got official statements from the FDA and the American College of Obstetricians and Gynecologists, and just a mountain of guidelines from private aesthetics clinics.
Right, which contradict each other quite a bit.
Oh, completely. So our mission today is to cut through all that jargon and answer one highly specific question for you. What is the actual difference between a G-shot and intimate fillers?
Because, online, especially on social media, these terms just get thrown around interchangeably.
We really do.
But they are radically different procedures. They serve completely different functions, they target different anatomical areas, and they carry vastly different risks.
Right.
So my goal today is to help synthesize these competing claims, separate the physiological facts from the commercial fiction, and figure out what these procedures, actually do to the body.
Okay, let's unpack this. Because to understand the difference between these two procedures, we first have to physically map the territory.
Right, the anatomy.
Yeah, the what and the where, because the goals of a G-shot versus an intimate filler occupy totally distinct real estate on the body. Let's start with intimate fillers, which I also see referred to in our sources as like labial puffing or vaginal fillers.
Yes.
Where exactly are we on the map for that one?
So with intimate fillers, the focus is strictly on the exterior.
Okay.
We're talking about the labia majora, which are the outer lips of the vulva, and sometimes the mons pubis, which is the tissue mound just above the pubic bone.
Right.
The goal here is primarily structural and comfort-based, because over time, due to natural aging or childbirth or, the hormonal shifts of menopause or even significant weight fluctuations, the labia majora just lose volume.
It just deflates, basically.
Exactly. The tissue loses collagen and elastin, leading to a deflated or wrinkled appearance.
But it goes way beyond just the visual aesthetics, right?
Yeah.
Because the sources highlight some pretty severe physical discomfort that comes with that loss of volume.
Oh, absolutely. When that tissue loses its natural plumpness, its padding, basically,
Yeah.
women experience significant friction during just everyday activities.
Like what?
Well, think about the mechanics of riding a bicycle,
Oh, sure.
or wearing tight clothing, like yoga pants, or even just walking long distances. Without that structural padding, the more sensitive inner tissues are exposed to constant chafing.
Ouch.
Yeah, it can be really painful. So intimate fillers are designed to restore that last volume to act as a physical buffer.
Okay, so if the target for intimate fillers is completely external and focused on structural padding, how does the G-shot or G-spot amplification, as it's called, how does that contrast with it?
Well, the G-shot is an internal procedure,
Yeah.
and it is strictly functional and sensory.
Okay.
It has absolutely nothing to do with external aesthetics or physical buffering from your clothing. The target is the anterior or front vaginal wall, usually about 1 to 2 inches inside the vaginal canal, positioned right between 11 o'clock and 1 o'clock.
And this is named after Dr. Ernst Greffenberg, right?
Yes, exactly.
The physician who first described this highly sensitive erogenous zone way back in, the 1950s?
That's the one. So the intention of the G-shot is to inject a filler directly into this internal area to magnify the G-spot,
Magnify it by how much?
sometimes ballooning it up to 4 times its original size.
Oh, wow. 4 times.
Yeah. And the working theory behind this is simple mechanics. By making the area larger and more projected into the vaginal canal, you increase the amount of direct friction it receives during intimacy.
Okay, I see.
And that increased friction theoretically enhances sexual pleasure. and facilitates a deep vaginal orgasm.
Okay, so if we're looking at the body like a house.
I like this analogy.
Right. Intimate fillers are basically like a structural home renovation. You're fixing the exterior siding, you're adding some thick insulation to protect against the elements, and just improving the overall day-to-day physical comfort of living in that house.
Exactly.
But the G-Shot is like upgrading the internal wiring of one very specific room solely so you can have a high-powered entertainment system.
That is a perfect way to put it. One is about restoring a protective external barrier, and the other is a highly targeted internal sensory upgrade.
Okay, but if the G-Shot is making this internal structure 4 times larger, what exactly are they injecting into the body that it doesn't just, immediately reject?
Right, the materials.
Yeah, because the where is different, but the what reveal exactly how these treatments are manipulating human tissue.
What's really fascinating here is that despite having totally different goals and locations, both procedures rely heavily on the exact same materials.
Really?
Yeah. The two most common substances are autologous fat.
Which is fat from your own body, right?
Yes, taken from your own abdomen or thighs via liposuction, purified and re-injected.
Okay.
And the second one is cross-linked hyaluronic acid, or HA, dermal fillers.
Okay, hyaluronic acid, we see that ingredient plastered on like face creams everywhere, and I know it's the standard for lip fillers.
Right.
But how does it actually work inside the body to create that kind of massive volume?
So hyaluronic acid is essentially a microscopic sponge. A single molecule of HA can hold up to 1,000 times its own weight in water.
1,000 times. That's insane.
It is. So when a clinician injects it into the tissue, it doesn't just sit there as a static lump of gel. It actively draws surrounding bodily fluid into itself.
Oh, I see.
That water-binding property is what puffs the tissue up instantly and provides that mechanical support.
Wow.
And it also means it helps combat tissue dryness, which is a major secondary benefit for the exterior intimate fillers, especially for menopausal women.
That makes a lot of sense. Which brings us directly to the brand new 2026 pilot study published in G-Science Central by researchers Barber and Iglooz.
Yes, a very interesting study.
Because they took a really revealing look at how AHA functions internally for the G-Shot specifically. They looked at 16 sexually active women who were specifically seeking anterior vaginal wall augmentation because they were experiencing decreased sexual satisfaction.
Right. And they divided these 16 women into 2 groups to compare treatments. Half of them received an injection of 2.5 milliliters of cross-linked HA directly into the submucosal layer of the G-spot area.
Now, just to clarify the anatomy for you listening, the submucosal layer we are talking about, the spongy layer of connective tissue situated right beneath the surface lining of the vaginal wall. Correct.
That is the exact spot. It sits right beneath the surface mucosa, but above the deeper muscle tissue.
Got it.
Now, the other half of the women in this study received PRP, which stands for platelet-rich plasma.
Right, which you might have heard of marketed commercially in wellness spaces as the O-Shot.
Exactly. For PRP, they draw your own blood, they spin it down in a centrifuge to isolate the growth factors, and then inject that concentrated plasma into the tissue instead of a synthetic filler.
Okay, but measuring if either of these actually work seems incredibly difficult. I mean, better sex is a pretty subjective metric to put into a scientific data table, right?
It is, but to quantify it, the researchers used something called the FSFI, the Female Sexual Function Index.
Okay.
It's a validated, multidimensional clinical questionnaire. It measures desire, arousal, lubrication, orgasm, satisfaction, and pain on a strict numerical scale.
So it's very thorough.
Very. They tested the women at baseline and then brought them back 3 months after the injections to see what changed.
And the results they published were staggering. The group that received the hyaluronic acid showed a massive 68% improvement in their total FSFI scores at the 3-month mark. The researchers noted huge quantifiable gains specifically in the desire, arousal, and orgasm domains. Did the PRP group see anything close to that?
Well, the PRP group also saw a significant improvement, but it was markedly lower. It was a 45% increase compared to HA's 68%.
That's a pretty big gap.
It is. And the researchers attribute this massive difference to the immediate mechanical action of hyaluronic acid. Because HA acts like that microscopic sponge holding water, it works instantly.
Right.
It provides immediate volumetric enhancement. PRP, on the other hand, relies on a process called neurovascular modulation.
Meaning it actually encourages the body to slowly grow new blood vessels and nerve endings over time rather than just instantly plumping the space up.
Precisely. PRP forces the body to regenerate its own tissue, which takes months.
Yeah.
So the 3-month mark of the study, the PRP group might not have reached their peak physiological efficacy yet, at least compared to the instant high-volume gratification of the HA sponge.
See, here's where it gets really interesting for me, though. We are talking about hyaluronic acid.
Yes.
Whether it's in your lips, your cheeks, or your anterior vaginal wall, HA is entirely temporary. The human body naturally metabolizes and absorbs it.
That's true.
And according to the clinic guidelines in our stack of sources, these intimate fillers and G-shots only last about 6 to 12 months. And looking at the costs, clinics are charging anywhere from $1,000 to $1,750, with some quoting upwards of $2,500 per session.
It's not cheap.
For a procedure that takes less than 30 minutes. Aren't patients basically signing up for a very expensive recurring subscription service for their own anatomy?
Well, you could certainly call it a vanity subscription if you're strictly looking at it through the lens of aesthetic enhancement.
Right.
But from a clinical perspective, if a patient is experiencing chronic physical pain from chafing against their clothing because they've lost that protective tissue volume.
Yeah, the intimate fillers.
Exactly.
Yeah.
A twice-a-year HA treatment isn't just a subscription. It is a massive quality of life improvement. They're essentially paying to maintain a pain-free baseline.
Okay, I can see the argument for the exterior intimate fillers providing physical relief.
Right.
But for the internal G-shot, does an artificial mechanical change actually guarantee the promised sensory result?
Yeah.
Like if you plump the tissue with a waterlogged sponge, does it automatically translate to better neurological function?
It's a great question.
Because reading through the official medical guidelines here, the broader medical community seems severely divided on this.
Oh, they are.
Yeah.
We have this intense contrast between private clinic marketing, which, guarantees enhanced pleasure and confidence, and the official medical consensus, which is deeply skeptical of the underlying science.
So like the ACOG statement.
Yes,
Yeah.
Look at the stance of the American College of Obstetricians and Gynecologists. They have stated on the record that there's absolutely no accepted medical evidence or valid medical reason for G-spot amplification.
None.
None. Furthermore, injecting hyaluronic acid into the vaginal wall for this specific purpose is entirely off-label. It is not FDA approved. The FDA has even issued strict warnings regarding the marketing claims of various vaginal rejuvenation procedures, stating they have not established safety or effectiveness.
So we have a 2026 pilot study showing a 68% improvement on a validated clinical index, and in the exact same breath, the major medical bodies are saying there's no evidence this works.
Yeah.
How do we reconcile those two completely opposite realities?
We reconcile it by looking at human psychology, not just the physical anatomy.
Okay.
The sources introduce a crucial piece of data here.
Huh.
The Weinberg meta-analysis on treatments for female sexual dysfunction, or FSD.
Right, I saw that.
This analysis is eye-opening because it measures the power of belief. It reveals a massive 67% placebo effect in FSD treatments.
Wait, hold on, 67%.
Yes.
If the placebo effect is that high, what do the actual numbers look like?
So to break down the raw data, patients in the placebo groups of these studies, meaning women who received a sham treatment that did nothing physically.
Just salt water or whatever.
Right. They showed a 3.62-point increase on their FSFI scores just from believing they were being treated.
Wow.
The patients who received the active real treatments showed a 5.35-point increase.
That means well over half of this cure is entirely in the patient's head.
Exactly.
The brain is doing the heavy lifting, not the needle.
Yes.
They are paying $2,000 for the idea of an enhancement. I mean, if I believe I've had a high-end medical intervention to improve my sex life, my brain essentially removes my own psychological roadblocks, and my body just follows suit.
It really highlights how deeply complex and biopsychosocial human sexuality actually is. You just cannot reduce it to simple mechanics.
Oh, clearly not.
And the science gets even more complicated when you consider that modern anatomy argues over whether the G-spot even exists as a distinct, isolated structure in the first place.
I read that in the sources, they refer to something called the clitorethrovaginal complex.
Yes, the clitorethrovaginal complex. Many contemporary anatomical reviews suggest that what we colloquially call the G-spot isn't a discrete button you can just locate and plumb up.
Right.
Rather, it is part of a much broader interconnected network. It involves the internal legs, or crura of the clitoris, the complex nerve network surrounding the urethra, and the vaginal wall itself. They all function together as a single unit.
Okay.
So when a clinician injects filler into the anterior wall, they might just be generally applying physical pressure to this entire complex. Or, as the placebo data suggests, they might simply be giving the patient an incredible psychological confidence boost.
A $2,000 confidence boost.
Yeah.
Which, if it works for you and you have the disposable income, maybe that's a trade-off you were willing to make.
Sure.
But that wild divergence between what private clinics promise in their glossy pamphlets and what medical boards are warning against it brings us to the most practical and, frankly, alarming part of this deep dive.
The safety regulations.
Exactly. If you decide to get this done, who is actually holding the syringe?
Right. If we connect this to the bigger picture of patient safety, we have to look very closely at the regulatory landscape. The Care Quality Commission, or CQC, standards in the UK, provide a perfect case study for how these specific procedures are governed.
Or not governed.
Exactly, or how they're completely missed by the rules. According to the CQC, if a clinic performs a surgical procedure, like taking fat from your thigh via liposuction and transferring it to your labia that requires strict registration, it is recognized as a highly regulated medical activity.
Well, that makes total sense. Liposuction is surgery. You want a registered medical facility.
But here is the massive loophole.
Oh.
Subcutaneous injections of substances used to alter appearance, like hyaluronic acid dermal fillers, do not legally require CQC registration.
What?
Because dermal fillers are largely categorized as cosmetic, non-invasive procedures under current frameworks.
Wait, let me get this straight. Injecting my own natural fat requires a strictly registered medical facility, but injecting synthetic hyaluronic acid does not.
Because of how the regulations classify the material itself, yet.
That is wild.
It creates a highly dangerous loophole where non-healthcare professionals, we're talking about high street beauticians, people without any formal medical degrees, could legally set up a clinic and perform intimate filler injections.
That is terrifying. We're talking about the genital region, not plumping a lip. What happens if someone without a medical degree gets this wrong?
The sources explicitly outline the catastrophic risks here. The vulvar and vaginal areas are incredibly vascular. They possess a dense, highly complex network of blood vessels and nerves. If an unqualified practitioner injects high-volume filler incorrectly, the complications go far beyond a bad aesthetic result. We're talking about permanent scarring, chronic tissue damage, severe systemic infections, or vascular occlusion.
Vascular occlusion, meaning the filler physically blocks the blood supply. Let's make sure we understand exactly how dangerous that is. Think of those blood vessels like a soaker hose watering a garden. If a beautician accidentally injects a thick, water-absorbing gel directly into the hose, the water stops immediately. The tissue downstream doesn't get any oxygen, and that tissue literally suffocates and dies.
That is exactly the mechanism of tissue necrosis, and it is a severe medical emergency.
Right.
When a board-certified gynecologist or plastic surgeon performs this procedure, as detailed in the G-Spot study, they use highly specific safety techniques. They pull back on the syringe plunger for up to 10 seconds before injecting a technique called aspiration, just to ensure they haven't accidentally entered a blood vessel.
Wow.
A beautician taking a weekend certification course in dermal fillers may not possess the intricate anatomical knowledge to even know where those major vessels are located, let alone possess the medical training to manage a catastrophic vascular occlusion if one occurs.
It really emphasizes the reality of this entire industry. Just because you can do something to the human body doesn't mean you should, and it absolutely doesn't mean just anyone should be allowed to do it to you.
The safety checklists provided in the clinical guidelines stress this point relentlessly. Any intervention in this area should only happen after a thorough, medically qualified assessment of the underlying causes of a patient's symptoms. A doctor needs to have a clear discussion with the patient about the very limited clinical evidence, and the patient needs absolute certainty about the medical qualifications of the provider holding the needle.
Right. So to synthesize this incredibly complex territory for you listening, we are looking at two distinct procedures that use the exact same microscopic sponge hyaluronic acid to achieve totally different goals.
Exactly.
On one side, we have intimate fillers, which are primarily aimed at restoring external volume to the labia, providing a physical buffer against daily friction and hydrating the tissue. On the other side, we have the G-Shot, an internal sensory-focused treatment aimed at artificially amplifying a highly debated anatomical zone in the hopes of increasing sexual pleasure. Both rely on temporary interventions, requiring you to return every 6 to 12 months to maintain the effect. Both sit right in the crosshairs of a fierce medical debate. You have localized studies showing high patient satisfaction, but you also have deep skepticism from major medical boards, a massive 67% placebo effect, proving the brain is doing most of the work, and a terrifying regulatory loophole that allows unqualified individuals to perform these high-risk injections.
Which really raises an important question that goes beyond the clinical data entirely.
What's that?
As a society, we are increasingly normalizing the treatment of intimate sexual function and anatomy with the exact same temporary cosmetic touch-ups that we use for facial wrinkles.
Yeah.
If we put sexual satisfaction on a commercial subscription model, how does that fundamentally change our relationship with intimacy? Does medicalizing sexual pleasure and packaging it as a quick cosmetic fix risk reducing human connection to a purely mechanical transaction?
It is a profound question. If that 67% placebo effect tells us anything, it's that perhaps our failure to address the psychology of female sexual health has created a market where patients are paying thousands of dollars just for the permission to feel confident in their own bodies. Our minds and our emotions play the biggest role of all. We want to thank you for joining us on this deep dive today. Keep questioning the glossy brochures, keep asking for the actual data, and remember, well, actually remember this. Sometimes the medical landscape isn't a clean x-ray. Sometimes you really have to navigate the murky waters for yourself.